Hello, everyone. Good evening. Welcome back. Let me make sure I've got my slides up here for you. Okay. We are going to get started. Welcome back, everyone. Welcome to the virtual stroke recovery group. This is our third meeting. I've been really enjoying it. I really love to get to spend this much quality time with you all, and I feel so strongly that knowledge and education is such a form of healing and empowerment in the brain health community, but we don't give you enough of it as doctors. And so my commitment to you is to try to speak as clearly as I can and help you understand what's going on with you. At the beginning of our stroke recovery, sure you can all hear me. Carrie, can you just let me know? Through text. Me and Carrie communicate through text. Okay, cool. All right, so I invited any of you out there who wanted to send me your MRI or your CT scan to send it to me, and I would be happy to help you interpret the interpretation. I can't read scans, but I can certainly decode the words for you. And so what we're going to do is every session, I'm going to start by going through different people's records and helping you all explain some of the jargon and what the implications are. So this week's records are really complex, and I'm going to do my best to go through them. And it really just reminded me of a few things. One is the spectrum of stroke survivors that we have with us, all the way from, a very mild stroke all the way up to about as serious of a stroke as you could possibly survive. And that is the case that I have in front of me today. This is a lovely mother and son pair from Athens, Georgia, the records are from Athens. I shouldn't say y'all live in Athens, but that made me very happy because one of my all-time favorite bands is the B-52s, and I know that they were from Athens. And so they gave me permission to talk about their records on the recovery group tonight. So I'm going to go through those with you now. So unfortunately, Cheryl's son was 39 years old when it seems like from these records, just completely out of blue, he woke up in the middle of the night with extremely high blood pressure, 260 over 160 when he got to the ER. And basically his entire right side went weak and he collapsed. And so when they first got him to the emergency room, there's a record in here. He got a CT scan, and the reason they would pick CT over MRI at first is because it's more in the realm of emergency medicine. It's quick, it's dirty. In about 10 or 15 minutes, you can tell, is this a bleed? Is there a tumor? Did this person crack their skull? So what they know immediately is that this gentleman had a large left basal ganglia hemorrhage. So that's our first little term to decode. So there's really two parts of the brain. There's the gray matter, which is the cortex on the outside, which we all think of as kind of those bumpy, slimy parts. And that's really where we store information. Those are like bookshelves. Then on the inside, we have what we call the subcortical area. And that's really like the motor. I think of it like the librarian. She might go out and pick out the book from the bookshelf, but then she brings it back. And so really it helps us store information in the cortex, but the middle part of the brain, the subcortical, has a lot to do with going out and finding information, learning information, retrieving it quickly. So the basal ganglia is really a bunch of structures put together. It's not just one part of the brain. And with CT, it's not fine-grained enough to be able to say this is exactly what part of the basal ganglia was impaired. All they know is that this is large. So in this case, it might have actually been multiple structures. And so in the basal ganglia, what I want you to know about that part of the brain, and the reason we're doing this is rule number one is make your map. You all need to know this about yourselves. The basal ganglia, you can really think of it as two pathways. So there's the direct pathway and the indirect pathway. The direct pathway is basically your gas pedal in life. It's what gives you your initiative. It's what helps you move your muscles. It's what helps you speak. It's anything where an activity has to happen. The indirect pathway is inhibition. It's the brake. Everything we do, even from taking my hand right here and going like this, it seems so easy, but after a stroke, you can realize how complicated this really is. So basically, I need my gas pedal to start, but if I never had a brake, I would just keep going, right? And people have that. It's called a dystonia, and their arm can just flail all around. I need the brakes in my brain to stop. okay? So what you can find in basal ganglia strokes is people can either, depending on the circuit that was affected, you can either have too much brake or too much gas. And, you know, too much gas is like disinhibition, you know, putting your foot in it, you know, being inappropriate. Sometimes people curse a lot after a stroke, but all too often people have the opposite, where it's too much brake and there's not the initiative that we would really like to see for a full active rehab. Sometimes the brain is just too damaged in order to do that. Okay, so then what happened to this gentleman is he got multiple brain scans over a very short amount of time, probably because of how big the stroke was. And what they were really monitoring is the level of hemorrhage and if his brain was doing something called a herniation. So the skull is obviously super strong and very finite, and the brain within the skull it's pretty jam-packed in there as it is. So if there's any extra visitors like blood products, the brain is remarkably able to actually scrunch itself up, twist, go all the way, try to go like a little far in the frontal lobes to basically accommodate for the blood. When the brain goes either left or right, forward, it's bad, but it's not catastrophic. That's what happens at the beginning of a bleed. Over time, if there's too much blood and we don't have a craniotomy and we don't evacuate that blood, what we actually see in the worst case scenario is that the brain actually starts to herniate backwards, and you actually start to get other hemorrhages in the back part of your brain. And unfortunately, that's what we can see here with Mr. Ward, that as they scanned him more and more over time, what they started to see was different parts of his brain were hemorrhaging. So his pons now, back in his brainstem, is actually starting to have some bleeding. He had a sign of what we call a midline shift, which, you know, when the brain is healthy, you got your left hemisphere and your right hemisphere, and they live there. That's their real estate. When there's too much of a fluid, too much blood or cerebrospinal fluid, that's when we start to see that the brain can actually scrunch up in one direction. So this gentleman had a midline shift at first, and then ultimately the brain seems to have gone backward. One of the things that stood out to me about these records was they list in the discharge summary all the consultations that happened for this gentleman. And so there was neurology, neurosurgery, infectious disease, because it seems like he caught some pneumonia from the ventilator, which happens and is unfortunate, gastroenterology. But I just thought it was very sad but telling that there was no psychologist seemingly caused in on the case. You know, this is a 39-year-old man who was extremely healthy, and I can't even imagine what a catastrophic experience this was for his family and him and his friends. And so I just really think we need to do better in stroke rehab, getting people the comfort that they need. So then what happens is more and more scans are done, and over time you can actually start to see where there was area of hemorrhage. We now have areas of encephalomalacia. And if you remember from Jerry's scan, he so nicely shared with us, that's part of what he was having too. And so basically, it's when it's a sign of brain damage, and the brain, we kind of think of it as like softening of the brain, which is showing that it was significantly damaged. So then I can see he was in the hospital for a month, and then he went to a long-term care facility, which I can only imagine how impaired things were for you, Mr. Ward, because as they scan you more and more over time, I think you had about as much damage from a stroke as a person can have and still be alive. So I'm going to fast forward now to a scan that they did. This was more recent, and what they like to do is then compare back to the time of the stroke, because we get a sense of how much of the brain has ultimately been injured and how well it's healing. And so the family was nice enough to send me a scan. So the stroke happened in 2015, and then I have a new scan from 2019. So I'm going to end the interpretation by talking about that. So it's a very detailed report. So now we're actually getting an MRI with and without contrast. So remember, this is a much finer grained picture. It's much more clear. We can really understand what parts of the brain are involved. So what we're seeing now is really two findings. The one is ongoing signs of the damage that was done in 2015. So there's something called a Wallerian degeneration which is really just a sign of atrophy, very similar to encephalomalacia, just kind of another term. But we're also seeing something else left behind from the stroke because there was so much blood. And some of you may have this finding as well. So studies can actually pick up on old blood products in the brain, basically iron deposits that are left behind. So after a hemorrhage, the brain, this is part of neurofatigue that we're going to talk about tonight. The brain spends so much time wanting to get all molecules of the blood out because it's what it's called very caustic to the brain. It's like oil and vinegar. The brain does not want blood in it. It sends alarm signals. I don't want this. This is bad. Your immune system goes crazy trying to get it out. The immune system at first is able to clear away a lot of it, but something is left behind. So think about it like if you spill ketchup on a white shirt, you can scrub that ketchup out, but you're always going to have a little bit of that red stain left behind. It's not possible to fully clean it out. The removal of blood products in the brain happens years and years and years after people are done having their stroke. So they can see that in that left basal ganglia where he originally, probably from having his blood pressure that high, probably a blood vessel literally burst under the pressure of how much the blood pressure was going so high. So we can see that there's signs in here that there are still little bits and pieces of iron from blood. That for many of you, if you have post-stroke seizures, we think that's probably a big reason people go on to have seizures is because, again, the brain dislikes blood so much that it irritates the brain matter and it can just make the chemical electrical transmission in the brain matter in that area go wacky. And that's basically what a seizure is. There's a ton of information in here, but I hope that that was helpful to some of you. I found those records really emotional. It's just amazing that to really appreciate what families and human beings go through when they have a stroke. And it just makes me feel so happy that we're all here together to process it as more of a human experience than just, you know, some medical issue related to a part of the brain, because it's so much more than that. Okay, so here's what we're gonna do. We're gonna recap rule number 2. I hope many of you were with us last week, and what we focused on was the rule of build on what's familiar. So based on this second session, I hope that you were inspired to bring more of you into this rehab. Research shows that therapies that are personal to you are much more empowering, more motivating, and lead to you getting better quicker. So I hope that you took that to heart and thought about ways to personalize your therapies, to personalize how you get motivated to do them, personalize how you reward yourself after, and we really focused on the power of music as an unbelievable way to really add some life into your therapies. And that's actually very helpful today, because what we're going to talk about is how incredibly important it is to fuel yourself to do this hard work of therapy that we know is required. So we talked about how the brain is organized into these very large networks across all different areas of your brain, and that they are very interconnected and they're very unique to you. Your brain is your brain. It's just like your thumbprint. There's no two brains in this world that are the same. So we talked about that you can really use the rule to apply it to any post-stroke symptom. So this is if you want better use of your hand, if you feel like your words aren't coming out like you like, if you're trying to transfer better from, you know, the chair to the bed. The whole idea is really building the networks. And we know that the best approach is when we go very systematic and we really customize it to you, because that's how those networks were built in the first place. So we talked about how stroke damages a specific part of a network, and recovery, you can really think of it like kind of rebuilding a house. The job of rebuilding, unfortunately, is very slow, and we all wish it was quicker, but with instruction from experts who understand the architecture of your unique brain, our goal is to rebuild these networks and to get you back to better functioning. And really the main point of rule 2 was to remember that you are the best brain glue for rebuilding your brain. You are the glue. So now we're going to transition into rule number 3 tonight, and this one is repetition and consistency. And the reason this is so important is because it really is the fuel that we have to put in the tank to get those neuroplastic changes that we so desperately want. So when we are thinking about stroke recovery, go back here. Okay. My own head was covering my slides. Okay. What's most important after a stroke in terms of rehab and therapies and getting better is repetition and consistency. Those two words should kind of always be in your mind. So when we know that therapies are done intensively, repetitiously, consistently over time, that there are long-term significant improvements in the connections between the brains, which is really what the rebuilding is all about, right? Repetition is the fuel of neuroplasticity. Repeat, repeat, repeat. But if you repeat just in 2 weeks and you drop it and you don't go back, no. If you repeat, repeat, repeat on the first Monday of the month, and then you repeat, repeat, repeat on the third Monday of the month, no. It's all about a schedule and consistency. Those two things are super important. Without consistency, we can have those connections fade, and you can feel like you're losing some of the progress that you've made. So what you really need to do is identify your symptom, right? That's our beautiful graphic with all the post-stroke symptoms, and work with an expert to figure out what is the rehab, what is the exercise that I have to do, and figure out a way that you're going to do it over and over again. But I have two questions when I think of that is, what do you mean by over and over? What exactly is the right amount? And the latter half of our time together tonight, we're going to talk about neurofatigue, because I think that that is a real barrier. I know that from my patients. And what I mean by that is, sure, I can talk to you till the cows come home about how many of these exercises you should do, but if you don't have the mental or physical energy to do them, then it's not going to help you at all, right? You're the only one who can actually do it. So many of you have motivation, but the initiation is impaired to where you can't do it. Or it also sometimes feels like I'm just dead on my feet. I just took a shower and that was, all I can do for today. So we're going to spend a lot of time today talking about what exactly is neurofatigue and how can we do our best to treat it. So I want to make this point to you about repetition and consistency by imagining that what we are working on is a hand or an arm recovery. So there's many differences in why different people have trouble moving a hand or an arm after a stroke. You can have had a basal ganglia stroke, and with the way that most of the brain works is that things are crossed. So when you have an injury in the left part of your brain, we see it in typically in terms of our motor use, our physical abilities, we see it in the right side. And if we have an injury on the right side, typically it comes out on the left side of the body. Now with the cerebellum, that's a little bit different because that is more parallel. So if your left cerebellum is injured from a motor perspective, what do you do? It's going to be the left side of your body that's injured. Same thing for the right. Okay, so we're just going to imagine that we are someone who's trying to get the hand back, right? So no matter what the reason though, the consistent high intensity repetition is a scientific fact that this is the way that you're going to recover movement. There's many other things that we try to do in therapy, but with hand recovery, it's repetition, repetition, repetition. So neuroplasticity happens when a given task is done over and over and over on a schedule. But what I really want you to be aware of is that over time, we can't let the intensity or the difficulty be a flat line. We have to always be thinking about ways to make it more difficult and more challenging. That really is a rule of thumb when it comes to neuroplasticity, because the brain really thrives on novelty and complexity. And so we always want to try to be bringing new things in to kind of keep the interest up of the brain. So animal studies, which we've talked about this before. So in the world of stroke science, there are human studies and there are animal studies. We know a lot about stroke from animal studies because, I'm an animal lover, believe me, 40-year vegetarian. But the truth is that animals really serve a purpose in science, and it's because we can make them do whatever it is we want. And so what they do in these studies is they give an animal what they call a sham stroke. And so with this example of Mr. Ward, we could have an animal, a mouse or a rat typically, and we could actually go in and create a very similar stroke to the one that we think Mr. Ward had. You could actually increase the blood pressure on that little guy to the point where he would have a hemorrhage. But typically what they go in is they do a little stereotactic surgery and they open up the little brain of the rat and then they burn an area exactly where we would expect a human stroke to be. And then we can And then let's say that results in the right hand of this, the right paw of this mouse having a hard time using it. We can actually then take that little paw, put it in a machine, and basically set the machine to say 500 repetitions for this mouse and 30 repetitions over here for this mouse, and we can control the amount of repetitions that they have, and then we watch to see how much better each mouse gets, right? So what they know from animal studies is that we need approximately 400 to 600 repetitions per day to return brain-hand connection. Okay, so of course, you know, the question is, well, how many days? We'll get to that in a minute. So what you want to do when you're trying to get a hand back is you're not going to see a clenched hand that has no sensation and no movement. You're not going to wake up one day and it's going to be like this. That's not how it works. It's a very slow process. The first thing that people typically experience is sensation coming back. And a lot of times it's not a pleasant sensation. It can be like pins and needles. It can be kind of a burny feeling. As much as that stinks, it really is a sign for most people that they're starting to get some of the connections back. But you really have to fine tune your vision to appreciate the very, very subtle things that start to happen in a hand recovery. Okay, so again, like sensation, a lot of times people can focus on, you know, a forefinger, and it might be that you can move that little sucker like that much, right? If you don't realize that that's progress and that your work is paying off and your expectations are so big, you're going to ignore that little finger, or you're going to be like, oh, great, well, really, you know, what can I do with that? It's so important with motor recovery that you go really, really small with your expectations, because it keeps you going. And that's just how it is. Neuroplasticity takes time. It takes time for brain cells to grow new little dendrites and synapses. It doesn't happen quickly. It's a slow process. I remember reading one time about spinal cord injuries that given the right set of circumstances, the spinal cord can grow 1 inch of new nerve endings per year. Okay, now in the brain and in the central nervous system, like the spinal cord, that's amazing. That's huge. That seems little to us, but it just literally takes physical time to pass. Okay. So now let's actually talk about some data, and we're going to talk about how many days it actually takes. So there were a research study, 2002, with stroke survivors who had right arm weakness. And what they did is they put them in the MRI scanner, and they wanted to show that in a functional image, which is where you get a IV injection. Some of you might have had this, and they actually can look at how your brain's metabolism is. So what parts of the brain are, it's not a structure scan, it's a function scan, meaning what parts of the brain light up when you do certain things. So they put them in the scanner, and it was completely silent in the part of the brain. So this would be in the left frontal cortex that we know relates to right arm strength and coordination. So they were able to show this part of the brain was completely dormant, okay? Then they had people go through a pretty intensive finger movement rehab. So this was 6,000 to 7,000 attempts at moving that tiny little finger, and they did this for 1 hour a day for 20 days. And when they were done with 6,000 to 7,000 attempts a day, an hour a day for 20 days, these people were lighting up more in the part of their brain that was responsible for getting hand movement back. And these folks were actually able then to move their pointer finger just a little bit. And what's so important about that, because again, you might just think, oh, that's just a tiny little pointer finger. No, if you zero in on that and keep going, that's the beginning of the breakthrough. That's the beginning of building on that. That's the first step that happens. That's how hand recovery and arm recovery happens. It's slow, slow, slow. But look at that number, you guys, 6,000 to 7,000 attempts. I mean, if we just sit here for a minute, right? Oh God, even trying to do like 20, I feel like, oh God, okay, this could end. So think about how many repetitions in 60 minutes, your timing of how you would have to do that. I think that just blew my mind. But we're going to talk in a minute about how many repetitions are done during a typical outpatient rehab session, you know, insurance-based rehab. You're going to be blown away how it doesn't even come close. But I want to give you another example. So I just gave you a motor example, and now I want to give you a cognitive, or what we might call a cortical example. So this is aphasia. Aphasia is difficulty with language, and it can either be expressive, where you have trouble speaking, or it can be receptive where you have trouble understanding. Now, aphasia can happen because people lose muscle tone in their larynx. They can have trouble with the actual muscles in their mouth. That's typically called dysarthria, where people can slur a little bit. Sometimes you don't have these symptoms when you're fully rocking and ready to go, but if you get tired, if you get frustrated, sometimes people, a lot of people I know with stroke can get a little like slurry when they get exhausted. But true aphasia is that there's been damage in one of 3 parts in the brain. So look at my little picture here. If you can see the yellow, what I see here is Broca's area. And what Broca's area is really our expressive speech, our ability to speak. If you look on the purple area, what we call Wernicke's area, that is receptive speech, that is understanding. So typically, people have had stroke damage in one of those 2 parts, and that gives them their symptoms. But also, you can have stroke damage in that little part that you see is kind of a bridge called the arcuate facilicus. It's kind of the bridge between the 2 sections. That one's really hard. If you remember in our first session, we talked about direct brain damage and indirect brain damage. That's a perfect example of indirect brain damage because there could be nothing wrong with Broca's area and Wernicke's area, but if the bridge connecting the communication between those 2 is cut down, you can actually have impairments in both speaking and understanding, even though the speaking and understanding parts of the brain are perfectly healthy. I hope that that makes sense. So when we start to look at aphasia rehab, it's very clear that more is better. I mean, that's a golden rule, but especially for hand recovery, arm recovery, and aphasia, it's really that there's been the most research. I mean, who's to say specifically how it's just a good principle that more is better, but higher intensity training schedules with aphasia absolutely result in more language recovery. There was a study a few years ago that used pictures to cue naming. And what they found is that they needed to do at least 400 picture cards per session to get back word retrieval. And this only happened after they were doing about 3 hours of training. So let's just, 400 times 3, right? So basically 1,200 attempts at doing these flashcards over and over again. And then we actually started to see improvement. But remember, improvement isn't necessarily full recovery or perfection. Improvement can be the 80th time you saw the picture of the canoe, you were able to say canoe, and you got it out. The point is just, it's so many trials over and over again that we need. But here's the key. It's very easy to fall for this. It's really not about the blocks of time for rehab therapies. It's about the amount of actual tries. So I want you to look at this data here. So there was a study where they looked at 2 people, each doing a 30-minute therapy session. One person did 3 repetitions, and the other person did 397 repetitions. So it really doesn't matter if you say, I go to rehab 3 days a week to work on getting my hand back. That really doesn't mean much. What really matters is what you're doing in those 3-hour blocks, okay? So I want you to concentrate on the number of actual repetitions, not so much on just the length of time, because depends on your processing speed, depends on your motor speed, how many you can get done. So here's what is extremely depressing to me, that most post-stroke therapy sessions have 40 to 60 repetitions per session. What did we just learn from our MRI finger scan study? Took about 6,000 to 7,000, okay? What did we just learn from our aphasia study? Took about 1,200. So that is something you absolutely need to know, because if you're someone who is overachieving in this recovery and you want to try everything possible, this is really why I do this group. You can't rely on what Blue Cross Blue Shield is going to pay for in order to get the type of recovery that you want. Okay, so you need to know this information so that way you can do it better. Thank goodness we are moving towards something in rehab called massed practice. And I want to tell you about this because, I can get down on the medical community a lot, but I call hope when I see it. So we know this. Research is telling us that current outpatient therapy sessions just don't have enough repetition to get people the best recovery. Now, I want you to kind of chew on this for a minute. You all know this better than me. How many months does insurance typically cover for outpatient rehab, right? So where I am in North Carolina, what I'm seeing is 10 to 15 sessions, which typically takes people about 2 to 3 months, okay? Sometimes you get a great therapist and they advocate for you to get more sessions if you're showing improvement, which they have their own idea of what improvement is. It's not really a decision you get to make, right? It's typically a decision that therapist makes or the insurance company makes. Does anyone else find that curious that we have this mega myth about stroke recovery that, basically you got the first, I hear sometimes 3 months is your biggest window and then maybe over a year, then they stretched it out to 2 years. And we know that this is it a bald-faced lie or a bold-faced lie? I never know that. Bald would be funny. I think it's bold. That is absolute nonsense. Recovery goes on and on and on. As long as you live, you're always going to be compensating. You're always going to be working on healing the brain at the physiological level, rebuilding the brain at the physiological level. It just determines what you do. So if you believe that crap, that things only get better after, things stop getting better after a year, well, it kind of lets the insurance industry off the hook, in my opinion, because, well, we're not going to give you any more rehab because science tells us you're not going to get better. So that's nonsense. So finally, a couple people got assertive and decided that they were going to basically try to change that. And the biggest therapy that uses mass practice is something called constraint-induced movement therapy. And I want to make sure all of you know about this, because if you have an affected hand or an affected arm, this is one of the most powerful rehab techniques that I know about. And I like it. I always like things that you can do on your own, and I always like things that are lo-fi. So what I mean by that is, like, you could go to Walgreens and buy what I'm going to tell you about, and you could do everything on your own. So what massed practice is let's just say your left arm is weak and it's not well coordinated, right? But your right hand is awesome. What you actually want to do is get a sling, put your good arm in the sling, and for 90% of your waking hours, okay, 5 times a week for 4 weeks, all you do is go throughout the day using that left hand for everything possible. You do not take your good hand out of the sling, and it basically forces your brain to have to put all its energy into getting that arm to have the expectation that it should be doing something. So this is such a fascinating part about the brain. So, when we close and open our hand, all we see is the outcome, the closing and the opening, right? But before we can actually do this, there's something called pre-motor planning that happens really in the front part of our brain. And it's stimulation to the brain that's basically preparing me for what I want to do by opening my hand. So this isn't all my brain is doing. My brain is doing all sorts of things in very small milliseconds to prepare. So if you've got your bad arm and you're walking around the kitchen and you want to get a glass of water, even if you can't go get a glass, bring it to the refrigerator and get water, just the idea that your brain would kind of have the instinct to want to go get a glass and get water, that is stimulating that part of your brain. Even if you can't move that hand at all, it's telling that part of the brain, get ready, we're going to do some kind of a movement. And that is basically electrical stimulation to the brain. So even if you have no use at all, there is logic, and it definitely helps people get some function back. You might also have an arm that's kind of online, but definitely has some trouble, and it might be frustrating because there's no strength there, but maybe you have a little bit of mobility. By binding up the good arm, it forces you to have to find a way. And remember, there's 3 types of neuroplasticity. There's actually figuring out how to rebuild those connections. There's finding out how to go around the problem with another part of the brain and get the same outcome. And there's acceptance. So I would say constraint-induced movement therapy really helps with number 1 and number 2. So it's very well established in the rehab world that doing this improves the quality, quantity, and the precision of movement. But for whatever reason, in my experience, not a lot of people know about it, but I think it's awesome. So then the idea is, okay, all right, Dr. Sullivan, you're telling me this is going to require a lot of repetition. Well, what do I get to do after the repetition? Okay. So remember what the enriched environment is that we are so desperately trying to create in your stroke recovery is intense, repetitive, consistent stimulation mixed with high quality, deep rest and sleep. Okay. So after you do anything intense with your brain, especially if it's a part of the brain that's injured and it's trying to relearn something, that's extremely intense work. The brain has to have time, rest, relaxation after the therapy in order to soak up all the goodness. If there's any yogis out there, you might know that after a really hard yoga session, the final posture is always Shavasana, which is where it's also called corpse pose, where you basically lay completely flat on the ground and you close your eyes and all you do is soak it up. And a lot of yoga teachers will tell you that's the most important posture in this session, is the resting and the absorbing and the soaking it in, because the brain needs time to go through that process of letting things kind of settle. Okay. So brain scientists know that the time immediately after multiple repetitions, it's really almost as important as the training itself. So what is it that I can recommend that you can do after an intense therapy session? Well, you can be like this little cutie pie here and take a short rest. I don't want you resting for too long though. So basically what the research tells us is 6 minutes to an hour. And why that's important is because when we sleep, when we deeply rest, our brain goes through a process called consolidation. And in 2 sessions from now, our whole meeting is going to be all about sleep. So I'm going to save some of that for then. But basically when we sleep, the brain does the most amazing things. And one of the things it does is it actually replays the day's events in our mind over and over and over again. And really all it's trying to do is to distill the lesson. What is it I should learn here? Okay. If we actually formed memories of every single thing we did in every day of our lives, we would be quite unsightly. Our brains would be, our heads would basically be like this, we'd be gross. And so, you know, we don't want that. And so the brain in its infinite wisdom basically tries to distill the day down. The way this research got started is with motor recovery, because what they did is they actually looked at people who were playing learning to ski video game, okay? And it was pretty complicated and you had to kind of learn how to go around trees and all this stuff. And they had college students do like 2-hour learning blocks on this video game. One group got to take an hour nap after the video game, but the other group got to just go and, you know, have a bite to eat. And they brought the 2 groups back, and the group that had slept got something like 40% better at the game just simply by sleeping, because when they were sleeping, we know this from mouse studies, that brain was just redoing those paths, refiguring out how to get around those trees, figuring out how not to die in the game. And so that way there was actual learning that was happening. You know, well, you know, 17 times when I did it to the far left, I wound up hitting a tree. The brain actually then learns the next time you do it, don't go so far left. And a lot of that is unconscious. It's not even something that we all think of in our mind with a thought. It's just our body then glides us differently because we are trying to get better at things. Getting better at life is really the goal of the brain. So isn't that amazing? So what we know is that the best results happen after a full night's sleep. The thing with the brain in sleep is that what it really wants is deep, continuous sleep. I sometimes ask my patients, you know, how is your sleep? Oh, it's pretty good. I get about 8 hours. Well, it's really 4 hours. Then I get up and then I'm reading and then I'm, you know, online and then I'm playing solitaire. And I understand sleep can be very difficult for many of us, but the goal is that deep, continuous sleep. And when we do the sleep lecture, we will talk about that. And I added a little quote here at the end, just because you really have to change the way you think about resting. And this is really individual for all of us, but rest is indeed not idleness nor a wasted opportunity for productivity. In the last few years, we've really been pushing this in the media and how science gets disseminated in the media, but sleep is very, very active, and it's really, really a necessity for all aspects of health. The other thing you could do if you're not feeling like you want to take a nap is simply get in a comfortable position and breathe properly. Deep breathing, diaphragmatic breathing is a very healthy thing to do. So many of us are chest breathers, right? So many of us are stressed out, we're tired, we've got too much on our plate. And a natural way of coping and keeping our energy high is, you know, we only bring in a breath till about here. So one of the very simple, portable, no risk ways that you can compensate for that is just simply focus and be intentional about your breathing. So diaphragmatic breathing, which is, you can see in my little picture here, some people call it a belly breath. And basically the idea is to be conscious of actually bringing the breath all the way down to your belly, holding it, and then blowing out a little bit harder than what you blew in. I'm going to teach you a technique in a minute, but just doing diaphragmatic breathing for a few minutes absolutely calms the nervous system. We know that it really helps with our emotional health, makes us feel less anxious. They have done studies that have shown in stroke rehab that when survivors are taught how to do diaphragmatic breathing, they report a lot less anxiety. And there's been a couple studies recently, 2020, that have shown that trunk stability improves after people do deep breathing. And they think part of it is the diaphragm is a big old muscle, and the more we get control of it, the more we can use that to our benefit for mobility. I thought that was pretty cool. So there's all sorts of muscles that go along with breathing. And so the idea is once those muscles are stronger, we can actually increase our capacity to do exercise and really help people's quality of life. So this is the 4-7-8 technique. This is from Dr. Weil. He's kind of the all-natural doc who's been around for a little while, but he just talks about very simply getting comfortable. If you can, put one hand on your chest and one hand on your belly. If you can't do that yourself, you can get someone to do that for you. And the whole idea is to try to breathe in the nose for 4 seconds, hold it for 7, can take a little while. And then when you blow out, I want you to try to purse your lips and make a whoosh sound. Believe it or not, they've done research studies, and that whoosh sound makes a difference. It's because it's forcing the air more out. So I used to think of deep breathing like you breathe in and you breathe out. You breathe in as much as you can hold, and then you breathe out as much as you can hold. But what you really want to do is blow out for about twice as long as the oxygen that you bring in. Okay, that's what we know is most healing for the brain. So the goal is 10 minutes a day, twice a day. You can do it in bed before you get up. You can do it after rehab. You can do it before bed. It's really good for anyone, caregivers, family members. Like everything else in life, though, it's consistency, right? It's dedicating to that schedule. So I'm always trying to encourage you to celebrate your victories, big and small, in this recovery. But this is a great time as well after an intense rehab session, is to really try to check in, become mindful. You know, where am I at in this recovery? What did I notice I could do just a smidge better this time than I did maybe 2 days ago? Okay, so when you just focus on only celebrating the big victories, you're going to miss a lot that's happening. And I really feel like that's where a lot of people's discouragement comes in, is they're not finely tuned enough to the subtle things that are happening. So here's a couple things you don't want to do. So you do a really intense, you know, physical therapy session, a speech session. You don't want to be stressed or have anxiety or, you know, get in a fight with someone or feel like you're not supported. These things have a very negative effect on brain recovery. And we think what it is it basically distracts the brain. The brain then gets focused on processing that emotional trauma and then doesn't have that time to just simply absorb and consolidate the information, which is exactly what it wants to do. So really important after a rehab session, make that time planned. Figure out what you're going to do. Our focus is so much on the hard work of rehab, which is important, but I also want you to make the downtime, the rest time, the soaking it in time just as much of a priority. But, you know, I'm an optimistic realist. And so as I was making this presentation, of course, there's a part of me that's like, yeah, this is all well and good, but what if you don't have the energy to do all of this work? And really important to bring the topic of neuro fatigue into this conversation. So as many as 85% of you out there have what we call neuro fatigue, and up to 40% of you report that the fatigue is actually the worst symptom or right up there with one of the worst symptoms. And I think what's important is those of us who haven't had a brain injury really have no idea how it feels to be someone living with neuro fatigue. So this is not the kind of tiredness that like you go take a power nap and you wake up and you feel great. Okay, this neurofatigue is either physical or it's mental. And the idea is the way people have described it to me, it's like you almost can't see, you're so tired. It's like a bone crushing kind of a fatigue. And it's thought to be very multidimensional. You can really feel it in your body. Some people feel like their thoughts are like walking through mud. Some people feel like their emotions, they're just so done. You know, a trauma of a stroke, a very intense recovery. It's exhausting. The way people treat you, the stupid things people can say to you. I mean, it really does take every fiber of your being, I think, for many of you to commit to this recovery, and that's exhausting. But the thing is that there's consequences of being really tired all the time, and the two that I worry about most are irritability, and where that really comes out is in relationships, especially person and caregiver. That's a real tender relationship. And then also it's like a perfect storm for depression. If you don't feel like you can even do things that would help you, it's very hard to feel like you have a sense of control, hope, or optimism for the future. Okay. Neurofatigue is a barrier to recovery. That's why we have to talk about it. It can delay a return to work, a return to driving, resuming your social roles, reduce your quality of life, and really can reduce your full participation in rehab. And what the research tells us is really in the first year, we should absolutely be prioritizing asking people about their fatigue level and then helping them problem solve how to work through it. But I could ask you all directly, are you finding that? Are people asking you when you go to the neurologist or the rehab doctor, is neurofatigue something that gets talked about? As always, I want you to understand why you might be having this symptom. There are three main reasons that neurofatigue occurs. The first one is your immune system has been on high alert since the day you had your stroke. It is working every minute of the day to heal your brain, and the time it can do its work the best is when you are in deep sleep. Number two is you're spending a lot more energy now doing things. And number three is you are processing emotional trauma in your sleep. And I'm going to explain all of these in a lot more detail. So let's go to the immune system first. Okay. When you sleep, your immune system can completely focus. When you are awake, your immune system is fighting germs. It is having to deal with all sorts of new invaders in the body, and it's got to suss them out and figure out, are they friend or foe? Is this something I should start building antibodies against? It gets distracted. Again, the whole purpose of your brain, your DNA, is to live. That is its only desire. And so if it feels that there is a threat internally in its brain through blood from a hemorrhagic stroke or the debris from an ischemic stroke, it wants it out of here. It wants to give it its eviction papers, and it wants to focus. So if you think of any time in your life where you've been pretty sick, like if you have a flu, all you want to do is sleep, right? But the flu goes away after 3 or 4 days. So imagine having that level of bone crushing fatigue all the time. So I had already said some of this. The brain is very aware that something is wrong, and it desperately wants to get us back to baseline. The other thing that's happening that's really cool is when the immune system is able to focus, it's creating and sending out all of these little guys here, this microglia. So a microglia is a specialized immune cell that lives in the brain. And I want you to look at its little green tentacles there and look what it's doing. It's going around collecting what they call cellular debris, and it basically brings it into its cell, and then it munches it up and basically gets rid of it. We kind of call them scavenger cells because that's really what they do. They're kind of like, what are those birds? I just saw one the other day. Vulture. They're kind of like vultures that go into the brain and pick up all the stuff that's left behind, all like the kind of garbage that gets left behind. So this process is the flip side of neuroplasticity. Neuroplasticity on one hand is the rebuilding, the regrowth, but we also have to get the bad out to start to plant the new. So you can kind of think of this as like a weeding process, and it's just constantly trying to clear things out more and more. Okay, you're spending more time and energy doing things now, right? So even normal activities after many strokes take more physical energy. You're definitely going to notice you get tired quicker. You need extra rest. And, you know, your brain used to be able to go from A to B to do a certain task. And now it may have to go from A to B to C to D to E to F back to A. Let me try B again. It's just literal energy, and you only have but so much energy in a day. And if it gets used up doing any given thing, you're running on empty. Again, this is one of my favorite parts of the brain. I'm a big fan of this function. This is the replaying of the tapes in your head at night. It's two different parts of the brain, your frontal lobes, which are kind of like your reasoning center, trying to figure out what's the point of something, and your hippocampus, which is your memory center. And they literally play images. It's so cool. Play images to each other all night long. And what they're trying to do is figure out, how did what happened to me today make sense in the big picture of my life story? And what emotional trauma is when those two things don't jive. If you have a normal day, and, you know, I'm a neuropsychologist, right? That's what I do. And today I had to go into work and I met with my team and we had to, okay, so when I go to sleep tonight, that memory of today fits right into my life story. I have a practice and I have awesome people that I work with, and we met, and it's just honky-dory and I'm at peace, okay? Imagine the sleep the night you have the stroke, right? Oh my God, I've lived a life all these many days here, and now this crazy, unexpected, really scary thing happened to me, okay? That process is like this for a very long time. It takes a long time for this to mesh with this, and it requires deep sleep. You're not really gonna get there unless you have good sleep. That's one of the functions of sleep, is to integrate that unexpected, scary thing with the rest of your life story and really figure out, like, what was that all about? How do I make sense of that? What's my meaning of that, okay? There are certain risk factors for neurofatigue. Some people get it more than others. One of the big ones is if you live alone. The more physically disabled you are after the stroke, again, probably much more energy has to be exerted to get you to function. If you had depression before the stroke, if you have developed depression after the stroke, you know, that's a very touchy subject, and I never want people to feel invalidated by what I say, and I think so many doctors do invalidate people that sometimes I feel like I get backlash, but I always try to make the point is, I'm not saying your depression is causing you to be this tired. It's not as easy as either or, okay? So some people who have depression have a lot of fatigue. If you have a stroke and you need a lot more help in life and you can't work anymore, guess what? That's normal to be depressed after that. You have to process it and work through it. But we do know that depression is kind of an independent risk factor for neurofatigue. This is very important to talk about, physical deconditioning. When I was thinking of Mr. Ward, he was clearly in a hospitalization, probably ICU, for, it looked like maybe about 31 days. You would not believe how much muscle wasting, how much your respiratory system can go downhill, even in a week of being in bed. Okay, so when people then have to go to rehab and they get home and they've been lying in a bed for, you know, a couple days, even, never mind a whole month, the body really needs to be rebuilt. That is very, very hard to have energy if your muscles haven't had use for a while, okay? Sleep disorder, again, this can be pre-existing before you had your stroke, or it can be caused by the stroke. Right now I'm working on, I think that is lecture 5, which is all about high quality sleep. So we have a whole hour and a half to go through that. But man, oh man, that is such an important thing to talk about. 70% of people meet criteria for sleep apnea after a stroke. 70%. Can you even imagine? And when's the last time, you know, someone told you that and, you know, you decided to go get a sleep study? Because that sleep apnea could absolutely be causing your neurofatigue, which then keeps you from doing all these repetitions. If you've had more than one stroke, unfortunately, you're at much higher risk for having neurofatigue. How long does neurofatigue last? The research seems to say that it begins really early, that the time of hospitalization and rehab is often a time of extreme exhaustion for our stroke survivors. And I think that's so important for us to know as outsiders, because it just really speaks to the whole idea of really trying to have genuine empathy and imagine what it's like to be in the shoes of that person. And here we've got physical therapy. You know, to be in intensive acute rehab, you have to be able to do 3 hours of rehab per day. And it kills me to think of some people don't get in because they don't meet that criteria. Well, the very reason they need the rehab is because they can't do the 3 hours a day. So there's like this very narrow accepted definition of who gets to have intensive rehab, and I hate So neurofatigue seems to go down a little bit at about 3 months when people get out of the hospital, but I hate to tell you this, but for many people, it actually goes on and on. So at about the 2-year mark, if you were highly fatigued at about 3 months, we think it's gonna last at least 2 years. And then 30% of you tell us that even 6 years after the stroke, that they still feel completely exhausted. So there are multiple things that can worsen neurofatigue, and I want you to know about them, because one mistake that we make in stroke recovery is we put all of our eggs in the stroke basket, right? And everything, your identity becomes about stroke. It's, you know, the only thing the doctors want to talk about. And I really want you to be an advocate for continuing to assert that you're a whole person and you have other physical needs that go outside of your stroke. So there are certain medications that can absolutely make you feel fatigued. One of the big ones is the anti-seizure meds, which you need. We don't want you to have any more brain damage from a seizure, but boy, they can really make you tired. If you take any kind of a pain medication, even something like gabapentin, certainly anything in the opioid family, you're going to be zonked. Some of you take things like baclofen for spasticity that can really make you feel fatigued. Some people take things like Xanax or Klonopin because they have super high anxiety. It's not to say you shouldn't take these. I just want you to be aware so you can make a risk-benefit decision with you and your doctor. Vitamin D and vitamin B12 deficiencies absolutely make people feel exhausted, so please get that checked. Uncontrolled diabetes is a huge one. When blood sugars especially go low, people want to go to sleep, they're tired. Any kind of a cardiac issue, congestive heart failure comes to mind. Very, very hard to have energy when you're not getting enough oxygen into your body. Thyroid disorders, if your thyroid hormone is low, you're going to feel sluggish and tired. Low iron, anemia is an important one to keep your eyes on. Sleep apnea. And then, you know, things like stress. When I'm stressed, all I want to do is go put the covers over my head and pretend that the problem doesn't exist. So that's an important thing for us to focus on. Loss of stamina and muscle strength, right? So when you're physically weak, it's very hard to have even mental energy. So all of those things, know about them, be honest with yourself if that's part of what could be going on with you, and go to your doctor if you can, and please tell them to work that up for you. So what helps with neurofatigue? Well, as of last year, when I did my last major literature search, there were no evidence-based guidelines for post-stroke fatigue. And what really bums me out is that it's very often not even on the table. There's not a standard evaluation question that they have to ask you. The different organizations make recommendations to doctors and rehabs about how they should follow people after a stroke. And I know that one of the things they focus on is post-stroke depression. So when you go back to your neurologist, you might get that question, you know, are you feeling like most days you're sad and you're not interested in things? I really wish they would expand those questions and include neurofatigue, because it has such a big impact on your ability to do your rehab. So this is cool though, like when they look at the research and they do figure out when places make it a priority what helps. You know what really helps people the most? I love this. It's education. It's just tell me why I'm so tired. Tell me how to do something called sleep hygiene, which is to really make sure I'm doing all the right behaviors to get a good night's sleep. Teach me how to actually relax. If I'm constantly tense and if my muscles are constantly contracted, I'm going to be exhausted because I'm never getting that release, right? You know, teach me what to eat. Teach me how to identify what makes me tired. Teach me something called activity pacing. That is a very, very hard part of stroke recovery, I think, is the transitioning from what you used to be able to do to what you can do now. And if no one's telling you how to do that, it's going to be hard to be successful. So there's a lot of literature from the chronic pain community that we can use in stroke that says this is how you actually pace yourself, okay? We also have to teach people how to identify when they're starting to get fatigued and not let people go to a 10 out of 10, and then we've literally got to spend days recovering. So what comes to my mind with that is like if you go to a party, a family party, and, you know, of course there's pressure on you to interact and you want to, you know, be as much of your quote normal self. I don't like that term, but I think you know what I mean. It's very stimulating, a lot of sounds, a lot of people, a lot of exhaustion. if you start to feel, okay, I'm in touch with myself, I'm mindful, wow, I think I'm really starting to get beat, and you just say, you know what, I think I'm going to leave now, and you're at a 5 out of a 0 to 10. 5 is pretty tired but not totally exhausted yet. Then you get to go home with a little bit of energy in your reserve. If you push it and you're not in touch and you go until you're at a 9, you know this, you're going to spend days recovering from that time of pouring out all that energy. So we need to help everyone figure out what really are the levels that are appropriate for them. And I think all that stuff that the research tells us really works. At the end of the day, I think it just helps people feel more in control of their symptoms. And I say this to you guys all the time. What I really can't stand is that people are suffering because we're simply not telling them information. That is what this is all about. So there are a lot of different causes of fatigue in non-stroke people, in people who've had a stroke. The issues ping off each other, right? So if you eat crappy food, a lot of sugar, simple carbs, then you're putting yourself at risk for diabetes. Even if you're pre-diabetic and your blood sugar drops really dramatically, now you're going to have a wave of exhaustion from that. So a lot of times the reasons for fatigue are kind of like this. But when you look through the literature, what usually helps people is a combination of techniques, and they're all personal. So it's kind of like what works for you. In the literature, time and time again, what comes up is the power of consistent, low-intensity exercise, which is counterintuitive because, Karen, if I don't feel like exercising, how are you going to tell me that I should be exercising? And that's what's going to help me. You just got to start where you are and try to incorporate a little bit more day after day after day. Even when it's like the last thing you want to do, if you're able to get out of bed and go for a little walk, if you're in bed and you're able to bring your feet up and down, if you're able to transfer in and out of the bed a few more times than you might normally do, just meet yourself where you are right now and then just try to take it to the next level. And when you get there, you just try to take it to the next level. It's really just baby steps. We really want to make sure that you're having high quality sleep, where you go through the 5 cycles of sleep every night as nature intended us to do. Sleep can get disrupted by not breathing, which is a sleep apnea. Of course, nature calls as we get older. If you drink too much alcohol early in the night, your blood sugar can go crazy. So there's a lot of reason that sleep gets interrupted. And again, that's why it's its own rule. And in 2 weeks, we're going to go through that. But that's a big priority. The pacing thing, really important. Sometimes you have to schedule short blocks of time to get things done instead of feeling like you can clean out the whole closet like perhaps you did before. One day you do this, next day you get the towels, the next day you take out the clothes you want to donate, more like piecemeal. Resting and not pushing yourself to that point of exhaustion and then putting yourself in the bed for 2 days, and delegating to others. This can be really hard when you're used to being the Energizer Bunny and go. But there might be certain things like, raking the leaves this year, and you might have to hire someone. Even honestly to the point of just kind of basic things around the house. Sometimes we need to ask other people for help because we're trying to reserve all that energy that we have. Nutrition is very important. I cannot overstate the importance of being hydrated when you have a brain health challenge, not just with water, but with high water foods, things like cucumber and watermelon. Depends on your blood sugar, but you can put a little salt on it. That really helps our bodies to retain water. Being honest with ourselves about our mental state, depression, anxiety, trauma, stress, these things really weigh on us. And especially when we're putting it outside our head and we're avoiding and we're trying to pretend that we're not bothered by something, what happens is it leaves the mind and it sets up in the body, and it really sets up in muscle tension. And when you're carrying around muscle tension all day, you're going to be tired because you're putting energy into simply existing. Keeping a lower temperature in the house, especially in the bedroom, has been shown to help with neurofatigue. Isn't that interesting? Pet and music therapy. We talked about the power of songs last time. Pets are so wonderful. Boy, that dog wants to go out for a walk. You're going to have to get up and walk that dog, or even having a cat come lay on the bed with the person, can sometimes motivate them to want to put their arm out and pet the cat. Strategic use of caffeine. I like this one as a coffee drinker. So, you want to be smart with caffeine. You don't want to have a cup at 3 o'clock in the afternoon, you're probably going to disrupt your sleep. But, using caffeine to wake up in the morning, I think that that's really okay. Alcohol is an interesting one with fatigue because sometimes we feel like it's going to help relax us, which it does at first, but it actually disrupts and fragments the sleep cycle over time. So let's just say you have a couple drinks, you go to bed at 9, you're probably going to be in a very deep sleep from like 9 to 10:30. But then when that sleep cycle ends, it's probably going to be all over the place at night, and you're never really going to sink into that continuous 5-stage sleep cycle that we're going to talk about in 2 weeks. Adjusting your expectations is really important. So again, probably in the beginning of your recovery, especially, not going to be able to do what you did before, and that's really important. But again, if we don't identify that as a struggle and teach you how to do it better, it's really not people's fault. Accept that stroke recovery take time. Many people, as I just shared with you, have extreme fatigue after a stroke. It's just part of the brain recovery process. And educating people that care about you. I'm not feeling lazy. I want to do those things. It just feels like my body or my brain won't let me. I wanted to talk a little bit about stimulant medications because in my experience, we don't use them enough in stroke recovery. I'm not a big pill pusher. I'm a psychologist, not a physician. I don't prescribe medicine, but I read the literature and I talk with my patients. Stimulants are basically wakefulness promoting agents, and you might know them from the treatment of attention deficit disorder like Ritalin or Adderall. In conditions that affect the brain like multiple sclerosis and stroke, they can really be helpful. And basically what they can do is they give you that zip so you can do the things that you want to do. And over time, the more conditioned your body gets, the more your respiratory muscles get strength, the more your brain starts going, the motor's really cooking. Sometimes people don't need them as much, or they can go down on their milligrams. They can just be a nice kind of a boost to put a little bit more in your tank. There's some people though that really can't use them. So if you have glaucoma, if you have significant cardiac disease, if you're hyperthyroid and it's not well controlled, if your blood pressure is still really high, or if you have a history of drug abuse, of course, we don't want to give you a stimulant. But in a couple studies, they've shown that modafinil is the most common stimulant for medical issues. 200 milligrams a day, people reported a significant decrease in fatigue and felt that the quality of their life was improved. So I just want you to know that, to have an informed discussion with your prescriber. I have no idea if it would work for you, if it's good for you. Here I see Jo is telling me her hubby is on Provigil, which she wrote is a narcolepsy med. Yeah, it's a stimulant, and it can be used to treat narcolepsy. It can be used to treat attention issues, but also brain-related fatigue, most commonly used in multiple sclerosis. Again, it's just kind of a funny thing. I don't know why it's not talked about or offered more in the stroke community. Does it go back to that whole idea that, well, you've got the small window to get better, and then honestly we stop putting in as much effort to getting people better? I hate to say it, but I kind of feel like that's the truth sometimes. So what I want you to do is, if you feel too tired to do your rehab, if you feel like your fatigue makes you depressed, if you feel like it keeps you from being social, if you feel like in any way it makes you significantly less able to live your life and do what you value, I really want you to have a conversation with your doctor about how important it is to you to treat it, and put your heads together with them to figure out exactly what it is that you can do to move forward. And really, after I've taught you this rule and you know how much repetition and consistency is needed for the optimal recovery, you kind of have to really sit with this idea like, okay, now I really have a choice, right? The brain is going to do more of what I make the brain do. And so even though I know there are barriers like neurofatigue, there are barriers like paralysis, there are barriers for initiation, I just want you to know this information. So even if you just try to do more, that's all that's really being asked of you. You might not be able to be completely successful with doing 7,000 repetitions a day. I'm not saying that. As long as you know what the goal is, then you really have a choice of how much you can try to get to that goal. Okay. So your self-empowerment statement for this week is, I value the roles of both hard work and rest in my ongoing recovery. If we just focus on too much work and miss out on rest, no good. Sometimes we are too much on the rest side, oftentimes because of initiation issues in the brain or neurofatigue. And we don't, it's not that we might not value hard work, but we just might not be able to do it as much. But really the point of this rule is you really need both, and you need to be educated about how to get to both. Okay, so we're going to do questions in a sec. Just wanted to say we'll be here again next week, October 8th, 4 p.m. This is a really fun one. Harness your creative power. Use creativity and the power of your thoughts to enhance your recovery. I really love that one a lot. It's actually really, really fun. The idea with that one is how to bring more life into your rehab. If you feel like things are boring, or it's not holding your attention, or you just feel like, you know, I need a little pizzazz, I need a little fun, that next rule is definitely for you. Okay, so Miss Joe again says we have a quadricizer. It's a machine that moves arms and legs. 20 days on that will have a good effect. In research, Joe, that's what it tells us. Every person is different, as you know. Every stroke is different, and I know from what you've shared with me about your husband, he really has a lot of, unfortunately, where his strokes were, he has significant symptoms. So it's really hard to say at the individual level, but it's certainly going to give him a much better shot at seeing some results. I think that's fantastic. So you can get him on that machine. I wonder, I'd be curious to know if you transfer him yourself or if you do that on your own. That's interesting. Maybe you could write into the Q&A and let me know. Okay. Jerry was sharing that he does constraint therapy. I would love to know, Jerry, if you think that it actually helps you. I really believe in that as a rehab intervention. I would love to know from you what you think. All right, let me go back down here. Jerry, is Carrie trying to take control? That would be good, because I'm not good at this. Carrie, if you can put Jerry through, I'll be very impressed. She'll try.
All right.
Jerry's. Oh, Jerry! Are you there?
I'm here.
Oh my God! It's a miracle of technology.
I know.
How are you?
I'm good. She's trying to get the camera going here. Oh wait, let's see here.
Hey,
Let's
Jerry.
plug this in, maybe.
Have you here?
Oh, come on. Let's see.
If I understood this stuff better, you wouldn't be struggling. So I apologize.
No. Let's see. Try one more time. Oh, come on.
While you try, Jerry, I'm going to read one of your other nice comments here. So you said last Thursday, I asked you guys about what's your motivation, and I talked about intrinsic, which is like things within you, or extrinsic, which is like things outside of yourself that motivate you, and I asked you to think about them. So good old Jerry said, my extrinsic motivator for doing therapy every day is starting my day out doing a modified therapy session with my wife. That's awesome. She motivates me and listens to great music throughout the day that I do with my other therapies. Isn't music like, it's just the ultimate boost. It just really can help us like focus. Music has really, I love music. My husband's a musician. I've been really interested in music in my life as a fan. I don't really have any talent, but in the COVID quarantine, when things have been so stressful, like the only thing that saved my mental health was walking with headphones on and listening to music, probably looking like a lunatic in my neighborhood because I'm like yelling and dancing and running around. But man, it really, really helped me blow off some steam, focus, and feel better, process things. All right. So Charles, our buddy here, said doctor recommended exercise. Yeah, it's absolutely an evidence-based therapy. But again, what I get afraid of is if we just tell people to do it and then they can't, there's almost that feeling of shame, like I'm not trying hard. And that's why I always want to couple it by talking about fatigue, because unfortunately, a lot of people just don't have it within them to put the amount of exertion that is required by a really intense therapy. So I'm glad he told you to do that, Charles, but did he help you understand how to take the steps to actually get there? Oh, you have a Hoyer, Joe, I see. Okay. That's amazing. I mean, because again, remember, you know, brain stimulation, getting different parts of the brain to communicate with the damaged parts and take over the functions. Stimulation can be active from a person. So it would be amazing if your husband could get out of the bed himself, transfer over and, you know, get on the machine. But even when you do have to do things passively for people, that is such an important point, is like, we can't let people just languish. If they have a significant paralysis or even motivational issues, even when we can get in there, you know, move hands around, massage someone's feet, give them a scalp massage, you know, move their arm for them over and over again. The body is designed to be used. And if a person can't use the body themselves, then, you know, those who love that person try to take over that function. And it's hard. I mean, you could, as a caregiver, I've seen people blown out their backs, you know, fallen when trying to pick someone up. That's why I'm glad, Joe, that you have a Hoyer. You know, sometimes people have a hard time getting those from insurance companies. But if you need it, I think it's an important thing to advocate for. Was that you, Jerry?
Me?
Yeah, no?
No.
Oh, well, tell me about constraint therapy. Do you think it's helped you?
Yeah. Can you hear me?
Yeah.
Oh, okay. It actually does. When I did it, they put my arm behind my back, my non-affected one.
Yeah.
And it does help, because it feels like, what is it called? My affected arm is makes you work a lot harder. And also the mirror therapy has helped me tremendously.
Oh yeah, that's so in the rule, harness your creative power. We're going to talk about mirror box therapy.
Yes.
I feel, Jerry, like that's another one, like constraint movement therapy. Like, why doesn't everyone know about mirror box therapy? Like, it's kind of a rarity. Not a lot of people know about it.
Yeah, I never did it until 9.5 years post-stroke now. And last year is the first time I've used it.
Wow. And you feel like you've seen results?
Yeah, oh, a ton.
Oh,
It really messes.
That's
Yeah,
so
it is pretty awesome stuff there.
So I'm going to explain mirror box therapy to you guys next week. And we actually worked with the distributor to get a discount code for people. So it usually winds up being what, Jerry, like $40?
Yes. I remember you talked about this. Boy.
I know.
Yes,
like,
a while ago.
Like a year ago, I think I did a Facebook Live about it. And again, what I love is it's not expensive. You can even make your own mirror box. Basically, you stick a mirror and you put your, oh, it's kind of a lot to explain, but basically you're trying to give your brain an illusion that your good hand is also working at the same level that your not so good hand is. And so you basically give your brain this illusion that both of your hands are working good. And again, because the pre-motor planning in the brain is such an important part of recovery, not just what you do on the outside, but the preparation and how you think about it. People really do get better when they use the mirror box. You can use it for pain. You can use it, usually people use it for a hand, but some people use it for their feet. But that really brings up too the importance of like imagery. Like we're going to talk about this next week, because stimulation is really the name of the game. Even if you can't do something, like, you know, I know that you're working really hard, Jerry, to get your arm back, right? Is it your left arm? No, your right arm. Because I saw you on the Facebook with that cool super techie arm. What do you call that thing?
The Hand Mentor by Modus Nova, and it does work. I mean, I've noticed it for my range of motion, my wrist has helped a lot. So
cool. That's awesome. We should talk about that some other time. But what was I going to say? I get so like excited about our conversations. I lost my train of thought, but I was, I know. The mirror box therapy. Oh, okay. I know what I was saying. Even if you rehearse in your mind mental imagery, if you visualize, if you daydream about using that right arm, and you like maybe imagine yourself playing tennis with the right arm, and just imagine in your mind like holding a tennis racket and your right arm swinging, and imagine it like make it very visceral. Like imagine the sound of the tennis ball hitting the racket. Imagine what it would smell like. Make it the most stimulating, complex thought you can have. And your brain, where the damage is that makes using your right arm hard, is going to be stimulated by those thoughts. And that supports the rebuilding of connections in that part of the brain. Sometimes we think stroke recovery has to be what we can see and what we can do and perform, but it can really also be how you use your mind. And that's really what Rule 4 is all about, is kind of this interesting idea of like, did a stroke happen to your brain? Or did it happen to your mind? I think for most people, it's more of a brain thing. And if we can figure out how to peel off the mind and use our thoughts and our beliefs, that's an important part of the recovery puzzle too.
Very true. Stroke is not for the weak.
Oh man, you guys are all so amazing. You know, you hear, what did I hear? I heard someone complain the other day on Facebook about, oh, how hard quarantine has been. And I don't know, like I haven't been out to a bar for 6 months or something. And it made me so mad, because I was just thinking like, that's really like what you're dealing with. That's the level of the restrictions on your life. I mean,
right.
People, you know, the brain health community in general struggles in a way that I don't think a lot of people on the outside really understand, you know, especially any of you who have kind of like invisible symptoms that other people can't quite pick up on. And, you know, people feel like if you don't, you know, have the classic stroke signs, and it's like, well, you're all right. You know, a lot of invalidating of symptoms, I think.
Yeah. And it's funny, you mentioned about a fingerprint. I always see the same thing. Every stroke is like a fingerprint.
Right, exactly. So then how can we justify having cookie cutter rehab, right?
Yes, last week when you said that, wow, that I took to heart to that, because it really, I mean, we have to do our own inventive therapies.
Somebody said that last week, right? I remember I was advocating for, you know, bringing in experts, and I remember a woman on here was like, you know, we're all everyone's own case manager. Like we're all out here just trying to piece it together, and that's really wrong. There's a hospital that I've talked to about this idea of having a neuro navigator, and I wonder what you guys think about this. It's a really cool idea, which basically after someone has a stroke, instead of, you know, oh, we'll see you again in 3 months, or, you know, we'll see you again in 6 months, is that you actually have someone that calls you, a neuro navigator, and they check in on you, you know, like 3 days later, 2 weeks later. And basically it's like, what are your care needs? Instead of just, oh, you come to us and you're going to see a neurologist. It's like, are you struggling to pay the bills? Do you need home care? Do you, you know, how are you feeling emotionally? You know, how is your family responding to you? And someone to just like oversee everything, you know, mind, body, and spirit, and not just, I just cannot get over the way people are turned out on their own after a stroke. That just bothers me so badly. It's just, I mean, I've had people in my office who've had a stroke and they weren't even admitted to the hospital. They went in, yep, it's a stroke. We don't have any beds. Like, you know, call your neurologist when you get home. I mean, it's just crazy how we don't really provide the support that we need. But, you know, what can I do about it? The thing we figured out how to do is to write the stroke recovery guide. And now that's how we got here with the group, is like, you know, I can share what I know, and then you guys can take this information out into the world and share it with other stroke survivors. And I think it's almost like an uprising of people is the only way we're really going to spread this information. Because I don't know if right now we can like count on them to really help us get it out there, you know?
Yeah, I love your guide, by the way. That stroke recovery guide everybody should have that.
All right, Maureen's telling me neuro navigator. Yes, it's funny because I was actually kind of volunteering for that role in my local community, because I just thought I kind of do that anyway. And then if I can make them make that a position, a paid position, then it kind of gets in their budget, and then they justify it to their board that this is needed in the community. And like I said, I feel like I kind of already do that anyway, but oh my God, how cool would that be if when you got released from the hospital or rehab, you literally had a human being, you know, ideally that you met along the way, you know, you met them in the hospital, they came to rehab, and like a human connection. So you don't feel like a number in this big system, that you actually feel like someone has your back and they're going to advocate for you. I think that would be a great step in the right direction. All right, you guys are all so awesome. Really, this is the highlight of our week here. I appreciate you all being with us so much. And remember that we'll be back next week. It really is a fun rule. Definitely will bring some spark and liveliness into your recovery. So thank you guys so much. If you're not signed up, you can go to the website listed here, SRG, and get back with us. I am more than happy again to take any emails with MRI scans or CT scans. If you give me your permission, I'm more than happy to go through them as we begin next week's session. So thank you guys so much, and I'll talk to you next time. Bye.